Central retinal arterial occlusion. They comes under retinal artery occlusions, which also includes BRAO and ciliaretinal arterial occlusions. We will be mainly doing CRAO in retinal arterial occlusions. All of the three have the same etiologies. First etiology is emboli. Emboli can be of cholesterol, calcium, and platelet fibrin. Cholesterol emboli is refractile, calcium is white, and it arises from the cardiac valve, whereas cholesterol arises due to hyperlipidemia. Platelet is dull, white, and arises from the atheroma of carotid artery. So these are the pictures. This is the white, and this is the calcium deposit. This is the refractile emboli of cholesterol. You can see the artery here. Next is atherosclerosis related thrombi. This is the second etiology. Third etiology is retinal arteritis with obliteration. And this includes giant cell arteritis, polyarteritis nodosa, SLE, Wagner's granulomatosis, and scleroderma. Fourth is angiosperm. Due to angiosperm, patient presents with amaurosis. Fifth is raised intraocular pressure. And sixth is thrombophilic disorders. Thrombophilic disorder is the inherited defect in the clotting factor, which manifests in young patients, whereas atherosclerosis, the patient is old. Seventh etiology is other causes, which is rare. Other causes include OCPs, they cause hypercoagulation. Another cause is polycythemia, increases viscosity and increases the chances of clotting. Another cause is antiphospholipid syndrome. Clinical features of CRVO. Also remember that the clinical features of CRVO are also applicable for BRVO and ciliaretinal artery occlusion because they are the same subtypes for the retinal arterial occlusive disorders. The first symptom is sudden painless loss of vision. This occurs due to the obstruction. It is sudden in nature, therefore it occurs within few seconds. History of transient visual loss, which is known as amaurosis fugax. Coming to the signs of CRVO, they are very important. First sign is visual acuity. So we test for visual acuity. This is markedly reduced to 3/60. Second sign is assessing the direct pupillary reflex, which is absent in these cases, and the relative afferent pathway defect can also be precipitated. Signs to look for in fundus examination are: first sign is narrowing of retinal arteries. The arteries appear thread-like, whereas veins are normal. Another sign to look for is milky white retina. This is due to the ischemia, which causes the edema. The edema make the retina to look white. Note that if the patient has the cilioretinal artery, which can be present along with the central retinal artery, the macula remains normal because of the supply of cilioretinal artery at the macula. Okay, this is the diagram which shows us the milky white retina in the periphery, but there is normal retina where I am drawing right now. This is the area supplied by cilioretinal artery. Another sign to look for is cherry red spots. Here is the diagram. Here at macula, there is thin portion, central portion called fovea. It is so thin that choroidal blood vessels are visible through it, therefore causing the fovea to appear red like cherry. Another sign to look for is cattle truck appearance. The cattle truck here represents the segmentation of blood column. Here you can see the cattle truck and the appearance in the retina. Next sign to look in the fundus is the atrophic changes. Attenuated thread-like arteries are seen. These arteries are visible after the edema is resolved. Atrophic appearance of retina is also seen. After fundoscopy examination, we can also do fundus imaging by OCT, which shows hyperreflectivity and thick inferior retina. FFA is fundus fluorescein angiography, which shows delayed arterial filling because it is CRAO, occlusive disorder. If there is retinal artery, then it fills first because it is normal. Here is the diagram of what we have discussed.